Good morning, everyone. So today we are going to discuss about community acquired pneumonia, particularly focus to ICU patients, critically ill patients. Community acquired pneumonia is one of the most common diseases that we clinicians face day-to-day in practice, and it is most of the patients actually got treatment in home-based treatment, and usually cured at home only, no need of hospital admission. But earlier the scenario was not similar, so there is quite a high mortality rate. So the father of modern medicine, Sir William Osler, called pneumonia the captain of main of death. Today, in fact, the annual incidence of pneumonia ranges from 5 to 11 per thousand population in Western countries, and the majority of cases of community acquired pneumonia are successfully managed outside the hospital, as I told earlier. But approximately 20% patient require hospital admission, and out of that, 10% had severe coronary acquired community acquired pneumonia and need treatment in ICU. So, what are the risk factors of CAP? Mainly the advanced age, comorbid illness like COPD, any ischemic heart disease, cardiovascular disorder, diabetes, neurological disorder, lung disease, and apart from that, cigarette smoking, alcohol abuse, and any kind of immunosuppression are present is a risk factor for community acquired pneumonia, along with genetic polymorphism in the immune response. So this is chart shows the risk factor for the poor outcome from community acquired pneumonia. So if we see the chart actually is divided into three parts. One is patient related, next is the pathogen related, and the third is the therapy related. So patient related are mainly like male sex and neoplastic disease, age more than 65 years, absence of pruritic type of chest pain. These are the associated to poor prognosis, along with some physical finding of the patient and laboratory findings of the patient like hypotension, tachycardia, tachypnea, high fever, confusion, leukopenia, high blood urea nitrogen, pleural effusion, acidemia, like this. And then pathogen related risk factor depends on the virulence of the pathogen, high risk organism, type 3 pneumococcus, staph aureus, and gram-negative bacillus pseudomonas infection. This could be associated with poor prognosis in community acquired pneumonia. And the therapy related factor is the most important for our point of view, because this can be changed outcome of the patient. And so delay in the initiation of antibiotic therapy more than 4 hours, initial therapy with inappropriate antibiotic therapy, and failure to achieve clinical response to empirical antibiotic therapy within 72 hours is associated with poor outcome in therapy related factors that can cause. So common pathogen causing community acquired pneumonia. So in this chart, actually, whatever the patient having comorbid disease or not, whether it is immunocompromised or not, the main factor is Streptococcus pneumoniae is the most common cause of community acquired pneumonia. Along with Haemophilus influenza, Mycoplasma pneumoniae, chlamydia, that this Legionella, microbial tuberculosis, and other virus can lead to virus infection like influenza is the most common, along with arbovirus, respiratory syncytial virus, Coxsackie virus. This can also cause in the community acquired pneumonia. The important is the thing is the risk for pseudomonas infection. The pseudomonas infection is a severe type of infection, as you know, and associated with severe type of community acquired pneumonia. So we have to look for the risk factor for pseudomonas infection. These are mainly structural lung disease like bronchiectasis, cystic fibrosis, corticosteroid therapy more than 10 mg prednisone per day, broad spectrum antibiotic therapy for more than 7 days in past month, and malnutrition. These are associated with high risk for pseudomonas infection. So this is a chart showing clinical association with specific pathogens. Like in case of alcoholism, Streptococcus pneumoniae, gram-negative bacilli, anaerobe, these are the common causing pneumonia. COPD patient, as discussed in earlier classes, that Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis are the most commonly associated with community acquired pneumonia. Similarly, poor dental hygiene is anaerobe, bad exposure, bird exposure, Histoplasma capsulatum, like this. And another thing is important, suspected bioterrorism, anthrax, plague, these can lead to community acquired pneumonia. Now, a little bit of pathophysiology. Actually, the source of infection is the microaspiration of infected oropharyngeal secretion and inhalation. This is the most common these two sources. along with hematogenous dissemination from extrapulmonary sites of infection, like in case of right-sided endocarditis, and direct extension from contagious site of infection such as liver abscess. This can be a source of the infection from where the infective metastasis can occur. And this is the earlier, as we know in pathology classes, that the stages, there is 4 stages of pneumonia: stage of hyperemia or congestion, stays around 24 to 48 hours, followed by stage of red hepatization and grey hepatization. Red hepatization 2 to 4 days and grey hepatization 4 to 8 days, and resolution phase, that is around 2 weeks, maximum up to 3 weeks. So most clinical finding what we have seen in pneumonia, that's come during this red and grey hepatization phase. Now come to clinical pictures. So in symptoms, we have to see the productive cough is the most common symptom. Then pruritic chest pain, dyspnea, high-grade fever. This could be present usually present in community acquired pneumonia. In elderly patient, pneumonia can have non-respiratory presentation with symptom of confusion, decreased appetite, lethargy, failure to thrive, altered functional capacity, deterioration in a pre-existing medical illness such as congestive heart failure, etc. And all these actually associated with poor outcome. Physical finding of pneumonia include tachypnea, respiratory rate more than 20 per minute. In ICU patient, we can see it is more than 30 per minute. Febrile, lungs auscultation can find long pipe crackles and sign of consolidation. Patients should also evaluate for pleural effusion because the parapneumonic effusion is one of the common findings in case of bacteriological cause etiology behind community acquired pneumonia caused by bacteria. Extrapulmonary findings should be sought to rule out the metastatic infection like osteoarthritis, endocarditis, meningitis, or to add a suspicion of atypical pathogen. Atypical pathogen can present with extrapulmonary finding also, such as micropulmonary pneumonia and cryptococcus, actually pneumonitis, not pneumonia. Which can lead to complications such as bullous meningitis, rash, pericarditis, hepatitis, hemolytic anemia, or meningoencephalitis. So now we come to little bit features are specific to pathogen. Streptococcus pneumoniae actually is the most common pathogen for community acquired pneumonia, and every 1/3 case of community acquired pneumonia is caused by Streptococcus pneumoniae. In case of comorbid patient or immunocompromised patient, there is drug resistant Streptococcus pneumoniae. Then Legionella pneumonia, that is the one of the another most concern for in pathology pathogen that lead to pneumonia. Infection is generally caused by inhalation of an infected aerosol generated by contaminated water source, air conditioning equipment, drinking water, lakes and river banks, etc. The diagnosis is suggested by the presence of pneumonia with proceeding diarrhea along with mental confusion. Hyponatremia, relative bradycardia, liver function abnormality can be seen. But this is not a typical in every patient. This is not like Legionella pneumonia is present in every patient with these symptoms, but it can be present in case of Legionella pneumonia. The urinary antigen test is the single most accurate diagnostic test for Legionella, but specific only for serogroup 1 infection. However, it does not detect other types of Legionella. So negative finding cannot rule out this infection. Mainly fluoroquinolone and macrolide are active against this infection. Now come to Staphylococcus aureus. This is important because this leads to severe form of community acquired pneumonia because of necrotizing. It can be necrotizing and development cavitary pneumonia. So it can have hematogenous dissemination to multiple sites of the body. The organism can also sit in the lung hematogenously from valvular vegetation in patient with right-sided endocarditis or from septic venous thrombophlebitis. So it can lead to metastasis to other, or it can from other side of infection. So when the patient develops post-influenza pneumonia, Staph aureus can lead to secondary bacterial infection. We have to keep in this in mind. Now come to severity assessment. So actually in case of ICU patient with community acquired pneumonia, mostly a severe community acquired pneumonia. So for severity assessment, there is multiple tools are there to assess the severity, but there is no one superior or inferior to one another. It has seen some has high specificity, low sensitivity, but some has high sensitivity with low specificity. In the year 1997, Fine et al. Showed the pneumonia severity index to predict the mortality, and this was followed by validation of CUR card 65 in 2002. Apart from the smart COP, that is SMART-COP, systolic blood pressure, multilocular infiltrates, albumin, respiratory rate, tachycardia, confusion, low oxygen and low pH, and the SCAP, severe community acquired pneumonia score are also there. As I told earlier, no one has 100% sensitivity and specificity. So this is important for whether patient to admit in hospital or at home or need for ICU admission. Along with the mortality of the patient, how much mortality prediction can be done by this the scoring system. But outcome of the patient more depend on the initiation of therapy and the appropriate antibiotic. So this is important, but not that much. Antibiotics are much more important than the severity assessment. So as you know from CARB 65 scoring is the one of the commonly used scoring. And C for confusion, U for urea, BUN more than 90 mg per dl, respiratory rate more than 30, systolic BP less than 90 or diastolic less than 60, age more than 65 years. Each scoring has 1 point. So each score 0 to 1, it is 1.5% risk of mortality, 2 is 9.2%, more than 3, 22% mortality. So when it is 4 and 5, we have to admit the patient. More than 3 or 3, we have to admit in hospital admission is required. 2, this inpatient versus observation. We can observe the patient in hospital. 0 to 1, we need outpatient care. We can patient treated in home basis. This is PSI index. This is depends on demographic, comorbidities, physical and vital signs, and laboratory imaging. So there is multiple parameters are there and divided into 1 to 5 points, and according to mortality, and same as earlier recommended for site of care. So it is actually, as I told, hospital whether they need help are asked to decide the patient whether need to hospital admission or ICU admission or home based care. The American Thoracic Society and the Infectious Disease Society of America (ATS and IDSA) recommended a set of major and minor criteria for ICU admission in 2007. These consist of one of 2 major criteria and 3 of 9 minor criteria. If it is hit, then patient should be admitted in the ICU. Like 2 major criteria: need for mechanical ventilation support or septic shock, need for vasopressor support, and 3 for 3 out of 9 minor criteria. These minor criteria include respiratory rate more than 30 per minute, PO to FiO2 ratio less than 250, multilocular infiltrates, confusion or disorientation, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension requiring aggressive fluid resuscitation. This is guided by, as I told, ATS and IDSA in 2007. But multiple studies going on regarding this, and some say the minor criteria only can be decided whether it can decide the patient need for ICU care or not. So the patient who are in ICU with community acquired pneumonia all are under severe grade of community acquired pneumonia. So investigation of a case of patient with community acquired pneumonia. So only physical finding, history and chest X-ray itself is enough to diagnose a case of community acquired pneumonia, and we have to start antibiotic empirically accordingly. Because this is the depends on the outcome of the patient, depends on how early we initiate the proper antibiotic therapy. So routine diagnostic workup includes chest X-ray. It is in hospital patient is admitted in hospital, then complete blood count, electrolytes, creatinine, sputum culture, pulse oximetry to diagnose moderate to severe coronary acquired pneumonia. In ICU admitted patient, after chest radiograph defines presence of pneumonia, testing should include assessment of the oxygenation, arterial blood gas analysis, routine admission blood work as I told earlier, and 2 set of blood culture, pleural fluid for diagnostic, and tapping of pleural fluid if present there is presence of pleural effusion to know the etiology. But same as I told, like severity, the etiology not that much important. Much more important is initiation of the therapy. Bronchoscopy is not indicated as a routine diagnostic test, and it should be restricted to the immunocompromised patient and selected individual with severe community-acquired pneumonia, like COPD on corticosteroid or immunocompromised patient and non-responders. Now, this is the diagnostic test for community-acquired pneumonia. In this chart, we show that chest radiograph has sensitivity of 65 to 85%, and it is the most first examination, radiological examination we have to done for community-acquired pneumonia. But the gold standard is HSCT thorax and CT scan of the thorax. But it not performed routinely but helpful to identify cavitation and loculated pleural effusion. Recommended to evaluation non-responding patient. Blood culture, the sensitivity is quite low, 10 to 20%, but in ICU patient, the blood culture is recommended. Not for routine blood culture, not recommended in hospital patient, but in ICU patient, blood culture is recommended. Sputum gum stain and sputum culture, oximetry or arterial blood gas analysis for both severity of the infection, need for oxygen, and hypercarbia if there is present. Serological testing, PCR for Legionella, Chlamydia, Mycobacterium, pneumonia, and viruses. This is accurate but usually requires acute and convalescent titers collected 4 to 6 weeks apart. So serological in testing also not routinely recommended. Legionella antigen sensitivity 50 to 80%, but as I told earlier, specific serogroup to 1 only. So, pneumococcal urinary antigen sensitivity 70% to 100% with specificity 80%. But false positive if recent pneumococcal infection is there. So can increase sensitivity with concentrated urine. Serum procalcitonin, it is also not a routine test, but if performed should be measured with highly sensitive Creptor assay. May help to guide duration of the therapy and need for ICU admission. Now comes to treatment of community-acquired pneumonia. Therapy for severe community-acquired pneumonia must be administered promptly and empirically using combination of antibiotic directed against pneumococcus, atypical pathogen, enteric gram-negative organism. If community-acquired pneumonia is MRSA is suspected, then therapy can be with either vancomycin or linezolid. Ceftaroline and ceftobiprole are newer antibiotics using fluconazole cephalosporin for community-acquired MRSA. However, since an agent that inhibits that toxin, community-acquired MRSA is part of toxin-mediated illness, the use of an agent that inhibits toxin production along with an antibactericidal effect can be used. So, in that case, linezolid can be done along or clindamycin can be added along with vancomycin for community-acquired MRSA pneumonia. Therapy regimen for severe community-acquired pneumonia. If there is no pseudomonal risk factor and with pseudomonal risk factor. So if there is no pseudomonal risk factor is there, as I told earlier, the COPD patient with any bronchiectasis or cystic fibrosis or long-term steroid, recent history of hospital admission or IV antibiotics, these are the risk factors for pseudomonal infection and malnutrition. So, selected beta-lactam antibiotics and intravenous administration macrolide and quinolones. And patient with pseudomonal risk factor, we have to give antibiotic that has the anti-pseudomonal coverage, like beta-lactam, cefepime, pyperosine, tazobactam, imipenem, meropenem, plus ciprofloxacin or selected anti-pseudomonal beta-lactam plus aminoglycoside and intravenous administered macrolide or anti-pneumococcal quinolone, moxifloxacin or levofloxacin. Along with this antibiotic therapy, other supportive therapy like oxygen, intravenous fluid, we have to give some adjuvant therapy for treatment of pneumonia. These are chest physiotherapy, aerolized humidification to reduce sputum viscosity, thereby enhancing clearance in patient with ineffective cough. Bronchodilator. Though the role of corticosteroids in routine therapy of community-acquired pneumonia is not established, corticosteroid may be beneficial in patients with sepsis and relative adrenal insufficiency, which occurs in a high proportion of patients with severe community-acquired pneumonia. So non-responder in severe community acquired pneumonia can be recognized as early as on 24 to 48 hours and requires consideration of unusual or drug-resistant pathogen, non-infectious disease that mimic pneumonia and pneumonia complication. So usually it takes around 72 hours to call a case non-responder pneumonia, community acquired pneumonia by not improvement in spite of antibiotic therapy or the deterioration of the therapy, increase the counts and deterioration of physical finding. Now, little bit of prevention. Prevention of pneumonia can be accomplished by focusing smoking cessation and immunization for pneumococcus and influenza, with consideration of a hospital-based immunization program. The 13-valent pneumococcal conjugate vaccine was approved by FDA in 2011 and for use for adults aged more than 50 years. And recent evidence suggests that using PCV13 in series with a 23-valent pneumococcal polysaccharide vaccine among patients more than 65 years of age. Not only pneumococcal but the influenza is that usually given every year, usually September to November month for prevention of influenza-related community acquired pneumonia.